presentation today is titled Nurse Navigators to Support Neonatal Transition, Enhancing Psychosocial and Medical Support for Parents of High-Risk Infants. And I'm going to start with a land acknowledgement. So we'd like to acknowledge the land on which SickKids operates. Of course, you might have a different land acknowledgement wherever you're calling in from. So for thousands of years, it has been the traditional land of the Huron-Wendat and Petun First Nations, the Seneca, and most recently, the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. SickKids is committed to working toward new relationships that include First Nations, Inuit, and Métis peoples, and is grateful for the opportunity to share this land in caring for children and their families. And if you have a local land acknowledgement that you want to share, you can feel free to put it in the chat. Thank you. So Alex already introduced both of us, our speakers today. So I'll be sharing the research side of things as a research manager here at SickKids. And Fabiana is coming to share her story, both as a parent with lived experience of having a child in the NICU and also as the executive director of the Canadian Premature Babies Foundation. And our talk today is going to cover Fabiana's talk, Living Through the NICU Journey, the Transition Home, and then our research study, background and rationale, the methods that we used, the results that we found, and our next steps. And objectives of our talk today. We hope that you will understand the experience of parents of medically high-risk infants admitted to the NICU. You'll learn about the novel role of nurse navigators supporting parents during that transition home and first year of life at home. And we'll discuss findings from the CCENT study and our next steps. So with that, I'm going to hand it over to Fabiana to share her story, Living Through the NICU Journey, the Transition Home.
Okay, thank you, Kayla, for the introduction, and Alex. And I also want to thank each and every one of you for joining this session today. I will start sharing my story to give you a glimpse of my journey through the NICU and the transition to home. So next slide. Yeah. Oh, so I'll keep this slide. So there is no, go back to the other one. Sorry, thank you. We're going to get this going. So there is a beautiful song by Cirque du Soleil that says that there is a day in our lives when our dreams and our fears must collide. That day for me was 13 years ago when I was expecting twins, and halfway through my pregnancy, we found out that one of our twins had a heart condition and zero chance to make to birth. I had gone through many years of infertility treatments. I had been blessed with a child 3 years before, and then the twins. I really felt that my life was perfect until that day. At 26 weeks, I was rushed into the OR. I had to have an emergency section. It was exactly 26 weeks and 1 day, and Mike was stillborn, and Gabriel was rushed into the neonatal intensive care unit, as known as the NICU. Next slide, please. When I first entered an ICU, I entered this brand new world. There were alarms, beeps, the smell of alcohol, incubators lined up side by side. Then I saw Gabriel wrapped in a plastic bag, covered in wires and monitors with a breathing machine keep him alive. An entire life contained in only 2 pounds. I asked myself, how was that even possible? Next slide, please. I was broken into 1 million pieces, afraid of losing him and even more afraid of asking what could happen. I just sat by his bedside and I watched him. The NICU has its own language, hundreds of acronyms. I had no idea what they were saying. And my strategy on the very first few days and few weeks was not to talk about Gabriel with anyone in ICU. I would talk with our NICU bedside nurses about the weather, their life outside the NICU, but never about Gabriel. The updates were given to Gabriel's dad, who would translate to me in mom's terms, in language that I could understand in a very small doses. And I decided not to think about the baby that I had just lost. My grief really had to wait. Next slide. As the weeks passed by and the alarms started becoming more familiar in the ICU, I was invited to join a research study called Family Integrated Care, or FICARE, and it truly transformed my experience as I became part of Gabriel's care team. I had education sessions every day. I participated in daily rounds, and I started making decisions with the medical team. Next slide. Peer support was a lifeline for me during our NICU stay. When it was just about sharing experiences, it was really about feeling seen, understood, and less alone in that environment. And we had peer support in many different forms. We had a graduate NICU parent who came by our baby's bedside, and she had walked this path before me and really gave me hope that I could also get through it. We had weekly education sessions for moms only, and that was like a really safe space where we could speak freely about our fears, how exhausted we were, and there was absolutely no judgment in those sessions. And that 1 hour a week became so sacred to me. It was the only time a week that I could actually breathe. Sometimes we cried together, sometimes we laughed, but every time we reminded each other that we were not alone. And peer support truly validated my emotions. It helped me to transform isolation into community. And I truly believe that that connection can make all the difference in a parent's mental health and healing journey. Next slide, please. So the NICU days for me meant 8 to 10 hours a day in the hospital. I was pumping every 3 hours, and I went home at night to spend time with my older son. But the NICU, it was still an emotional roller coaster with no end in sight. It was a one step forward, two step backs. Gabe was ventilated for 7 weeks. He had several infections, and the many conditions preterm babies develop, such as PDA, BPD, IVH, ROP, that required intervention. You see all the acronyms that I had to learn. Besides, Gabriel also had feeding issues, reflux, and all of that came with daily pokes, IVs, ultrasounds, x-rays, spinal taps, transfer back and forth to see kids for procedures. And all the medical decisions that I had to make with the NICU team were decisions that could impact Gabriel's long-term outcomes. And I have to tell you that seeing your baby going through all of this is certainly traumatic. I lived in a fight or flight mode for very long, barely surviving, because when you are in this situation, you absolutely have no choice. Next slide. We are finally able to take Gabriel home after 146 days. He was discharged on oxygen. We had to bring the hospital home. I was scared, but the NICU team reassured me that I was able to care for him at home. After all, I had spent over 1,200 hours by his bedside, and as a very good student, I attended all education sessions. But the preparation was still overwhelming. I have to make sure my house had all the equipment that Gabriel would need at home. I had to organize how I was going to run oxygen tubes between one floor to another floor of the house. And I was worried that my 3-year-old son would disconnect all the tubes and I was not going to notice that. And it was so overwhelming. I had to fill up prescriptions and I added the pharmacy on my speed dial. And I had all Gabriel's appointments scheduled for the coming weeks. Next slide. So the first weeks at home were challenging. I was trying to adjust to a new schedule with daycare for my older son and Gabriel's new routine. There was no nurses around to support, no more moms groups, no one to talk to, and managing with no sleep really with appointments around the city. Besides, was end of October, was RSV and flu season, and no one was allowed in my house as I was afraid Gabriel could get sick. But also, as an immigrant, I have no immediate family in Canada, like my parents, to eventually come and help out. So I felt very isolated, physically exhausted, and emotionally drained. Next slide. And despite all precautions at home, Gabriel had several hospital readmissions with respiratory infections. In one of them was shortly after the discharge from the NICU. Gabriel had pneumonia, and one morning in the community hospital, he couldn't breathe. I had to do CPR on him inside this community hospital, and I saved his life on his first Christmas Eve. And this photo was taken just a few hours later when he was transferred to the ICU at Sick Kids. I felt we were back to square one with CPAP and feeding tubes and all that again. While it was a scary and traumatic day, I was so grateful that I had the knowledge and skills to do CPR on Gabriel, something that I had learned during the education sessions in the NICU. Next slide. Gabriel also had other challenges. His development was extremely delayed. I knew he could be late because he was born so early and he was so sick. But even as we settled into our new normal, I was holding on to hope that Gabriel would still catch up. But deep down, I also knew we were heading towards a different path. And at 20 months old, he was diagnosed with quadriplegia cerebral palsy. Next. Well, it was a lot to take in. And on top of caring for Gabriel, I was also trying to navigate a very complex and fragmented healthcare system. This is Gabriel's care map from his first and second years of life. Every bubble you see represents someone involved in his care: specialists, therapists, early intervention workers, case managers, medical supply vendors, and more. I became the coordinator, the scheduler, the communicator, the person responsible for keeping everyone on the same page. In just that second year, we had 187 appointments. That's more than one appointment every other day. And each time we met a new provider, I had to retell our story from the beginning, reliving the trauma over and over again. There was no continuity of care, and no one asked how I was managing all of it. Everything was about Gabriel, his health, his progress, his needs. Next slide. Until one day, I took Gabriel to see a naturopath doctor. And for the very first time, someone turned to me and kindly asked how I was doing. And I be honest with you, I didn't know how to answer. I had to really stop and really think about it. I had to become so focused on surviving day to day that I had completely disconnected from my own personal reality. But that question was really a turning point in my journey. It made me realize that I also needed help. I had to start unpacking buried emotions, the grief of losing a twin, the trauma of watching my baby fight for his life for so long. I had a lot of guilt, fear, and the heartache of seeing other babies dying in the ICU. I had to learn how to make space for myself to heal and to rebuild a life that had changed completely. Processing the trauma of a preterm birth takes time and support, and no parents should have to do it alone. Next slide. While it was a hard reality and I had to deal with a lot of sadness, I also want to show you that when families feel supported, we can thrive and find joy along the way. For me, I really found a new purpose. My gratitude brought me back to volunteer at the same NICU where Gabriel was born. His neurologist at Sick Kids knew I was involved with a couple of projects at Mount Sinai Hospital and invited me to join a new group looking at transitions from NICU-to-home. And that's why I'm here today. Next slide. I realized that giving back gave me great joy. My volunteer days at Sinai led me to the Canadian Premature Babies Foundation, and we are a parent-led organization providing support and education for families. It's where I found meaning in this mess. It's where I turned my pain into purpose. At CPBF, I also learned that transitions for families, no matter where we are in Canada, in small or big cities, whether they are privileged like me or not, whether they are single parent or not, it's always hard. Families need support. They need to know that they have someone they can count on to navigate this complex healthcare system. And families need to know they are not alone in this. Next slide, please. So what I wish I had back 13 years ago when we left the NICU, and some of this is what the Canadian Premature Babies Foundation is trying to provide, as well as the CCENT project that Kayla will be presenting. So I wish I had a central care coordinator or a case manager, someone to help me to manage all the appointments, the paperwork, communicating between providers. So I didn't have to be the system navigator while also being a parent and a caregiver. I wish I had peer support in the community. There was something that was regular, structured support from parents who had been through similar journeys beyond the NICU days. I wish there was more mental health support, people who understood the trauma, who work with trauma informed care, that understand this unique emotional tool of the NICU, the grief, and raising a medically complex child without long waiting times and high costs. I wish there was bereavement support for parents who actually lost a twin, to create safe spaces and programs designed for us, because we are raising a child and grieving the dead one. I wish there was respite care, at least a few hours a week, so I could rest. I wish there was more support for dads and the siblings, because preterm birth impacts the entire family. I wish there was a smooth transition program from the NICU-to-home, home visits to really bridge the gap between the hospital and community care. And I think this is the dream for many of us parents and healthcare providers, to have this one centralized hub of information. And for us parents, I wish there was information in one portal about developmental milestone, funding options, early intervention programs, and who to call if I had questions. And working at the foundation now, I realized that across Canada, we need multi-language services, because navigating all of this in English is hard as it is. I know how hard it is for families who are newcomers and don't have English or French as their languages. So, next slide. I often say that I did not choose this path, that this path chose me. And why I would never, ever wish for the pain or the loss we endured. I'm forever grateful for what it taught me, that even in the darkest moments, light can still shine through. Today, Gabriel is not the only reason I fight so hard for change. He's my greatest teacher. Through him, I've learned what true resilience looks like, what it means to hold on to hope, and how to live fully in the present moment. And if there is one message I can leave you with, is this: that behind every NICU baby, there is a family holding on their breath. They're terrified, exhausted, and really hoping for a miracle. They are navigating uncertainty, making possible decisions, and often doing it in silence. But when we support that family, like really support them, we do more than help a baby survive. We really help a family heal. We help them find their voice, their strength, and their future. And you, all of this in this call today, you have that power every single day, whether it's through a program like the CCENT, which I love so much, or something as simple as sitting beside a parent, listening without judgment, offering a hand to hold, or guiding them to a helpful resource. You can be the difference between a family just surviving and a family truly thriving. So I really invite you to walk along with the families that you serve, because your presence, your compassion, and your advocacy can change the course of someone's entire life. Thank you.
Thank you so much, Fabiana, for sharing your story. I'm always grateful to hear it every time. I feel like it really brings a human element to the research that we're going to discuss and all of the numbers and statistics. It's really amazing just to hear everything that you went through and everything that you guys experienced. So I'm going to share the background of our research study, the CCENT study. It's funded by the Child Right Network under the CIHR SPORE Strategy for Patient-Oriented Research. And throughout all phases of our research, we value collaboration with parents with lived experience. So to do that in the CCENT study, we have a parent advisory group who we work with at all levels of the research project. So we have parents who have experience in the NICU, like Fabiana, and these parents are involved all the way from designing a research study to the output at the end, presenting our findings at conferences and writing papers. So they are involved when we're interpreting the data and writing it up. They help us with how to develop recruitment strategies for families, what helpful knowledge translation tools we should use to share our findings. They're part of focus groups and designing the questions that we ask or participating in them, trying to make our research accessible for parents. And so we're very grateful to all the parents in our advisory group that have helped with this project. To give you a little background on the population, so we mentioned medically high-risk infants. What does that mean? These are infants that are at risk of medical, cognitive, and developmental sequelae. So approximately 15,000 infants are admitted to Canadian NICUs annually. And we're seeing more and more of this population because of medical and technological advances that have led to increased survival of infants that are born preterm or with complex needs who are admitted to the NICU. So they may have complex medical conditions, frequent hospitalizations, and neurodevelopmental impairment. And when we talk about parent mental health in the NICU, we're seeing elevated levels of stress, anxiety, depression, and PTSD. There are a lot of stressors in the NICU, including the child's medical condition, their appearance, the NICU environment, the sights and sounds that Fabiana was mentioning, and changes in parent role from what you expected versus parenting a child that might have higher medical needs. And mental health support varies across Canadian NICUs with mixed results. So, in terms of the impact of mental health on infant development, we know that if we enhance psychosocial support for parents, that can decrease stress, anxiety, and depression, which in turn can improve parent infant attachment and longer term developmental outcomes for preterm infants. And the transition from NICU to home is a particularly important time period where parents are often leaving a sense of familiarity and a care team that they've grown used to from weeks or months in their admission. So that transition can be accompanied by a sense of loss that's compounding those mental health and stressful conditions that parents are experiencing already. After parents come home, they may take on a medical caregiving role for their child. As you saw with Fabiana's care plan, these children may be followed by multiple subspecialists, as well as neonatal follow-up programs that focus on neurodevelopmental outcomes. And psychosocial supports for parents are limited. This is mostly care that's focused on the child. So families and healthcare providers alike have identified that the tools to address a family's medical and social needs have to extend beyond the NICU to encompass that transition home and even extend into that first year of life. Supporting parents during the transition and that first year can help with reducing stress, improving mental health, increasing parent confidence in caregiving. It provides family-centered care, and it can help strengthen that parent-infant bond long-term. So, to support parents during that transition, we designed a randomized control trial, the CCENT study. It stands for Coached Coordinated Enhanced Neonatal Transition. And we've published the protocol of the paper, so you can find that online. It's through, I think, BMJ Open. And I'll run you through some of the design elements of the study. So our primary objective was to look at the impact of CCENT on parent stress at 12 months. And we measured parent stress using the Parenting Stress Index short form. This was a pragmatic randomized control trial, so we had an intervention arm and a control arm. It was conducted in 7 Canadian hospitals, level 3 NICUs across Ontario, Quebec, and British Columbia. And when parents went home from the NICU, it was just conducted virtually with the same person that they met in the hospital. And we had 275 parents of high-risk infants in the NICU that participated in the study. So this is just an overview, a map of those 7 sites that we mentioned across Toronto, Montreal, Ottawa, and Vancouver. And the criteria for this study were infants that we expected to have a more complicated course in hospital, as well as more medical follow-up long-term. So they could have met one or more of the criteria from this list. So extreme prematurity, prematurity with one or more risk factors, or those with 2 or more major congenital anomalies, and those who had hypoxic ischemic encephalopathy requiring therapeutic hypothermia while in the NICU. And And the intervention was delivered by a trained nurse navigator. There was one at each site who supported families for 12 months. So, meeting them in the NICU and continuing that support through the transition home and first year of life. And it was bundled support. So, these are the three main pillars. The first was anticipatory education. So, proactive education that targeted expected challenges in caring for high risk infants' healthcare and developmental needs. There was coaching and psychosocial support, which started in the NICU with 5 sessions and then through weekly and monthly check-ins throughout the year. And this was informed by acceptance and commitment therapy, which I'll talk about in a second. And the last pillar was care coordination. So focusing on relationship building, the parents doing medical and social problem solving through empowerment of the nurse, and the nurse helping them navigate with finding community resources after discharge. So, a little bit more on acceptance and commitment therapy, which was the framework that the nurses were trained in. It's an empirically based behavioral therapy that involves acceptance, mindfulness, and behavior change strategies. And the focus is really to encourage people to confront and to embrace and to accept their difficult thoughts and feelings that might be coming up rather than avoiding them. And then, with that acceptance, choosing actions in the present moment that can bring them closer to their values. It's been shown to reduce maternal depression, and it can be delivered by a range of trained facilitators. So it can be delivered by trained nurses, also trained parents and peers. So it's a very flexible like intervention that we applied in this context for the first time in the NICU. We had the nurses undergo a 3-day ACT workshop for training and then 1 day of general training around that care coordination and anticipatory guidance piece. We designed a manual with the curriculum, so that was standardized across all sessions, and it was developed with clinical psychologists. And then throughout the study, the nurses had biweekly facilitated peer support, so they had a call every 2 weeks where they would check in with each other. They could do problem solving and troubleshooting, as well as getting feedback on their ACT delivery, and they were able to do practice sessions with a trained social worker. So there was support for them throughout the duration of the study. This is just a zoomed out version of our study timeline. Essentially, parents were admitted to the NICU, they were enrolled in the study, they met the nurse navigator in person and had 5 sessions in person. Eventually, weeks or months later, they were discharged home. And from discharge to 12 months, the nurse was checking in through phone calls and emails, initially weekly, and then it tapered off to monthly after several months. And it lasted for that first year. And we were also collecting data through online questionnaires to measure parent mental health. And at the end of 12 months, that was the end of the nurse navigator intervention. We measured our primary outcome of parent stress, and we also interviewed parents for their experience in the study. So, results of our study. I'm going to share just some demographics first. So, the sample was predominantly mothers that participated. About 50% were immigrants to Canada, 83% married or living with a partner. For most of these parents, the child in the NICU was their first child. So, 30% had 2 or more children. And for 70%, this was their first child. And average birth weight quite low for these babies and also quite premature. So average gestational age was 28 weeks. We had the nurses document the main focus of every interaction that they had with parents in those phone calls and emails after discharge. And we were surprised to find that 70%, so the majority of those interactions, were supporting parent well-being, whether it was through mental health check-ins and well-being or just talking about personal updates from parents and how they were doing. And then a smaller proportion was actual medical questions, developmental questions, questions about the child's growth, and then help with social services and referral management was the smallest piece that we saw. And parents had a very wide range of how many interactions they had with the nurse. So we had the nurses calling them on a regular schedule, but parents were also free to reach out more frequently and talk to them more often as needed. So it was a very flexible delivery. And you can see in the range here, we had some parents that didn't engage at all. So they got the calls, but they didn't pick them up and they never responded to the emails, all the way up to 185 interactions. And the mean was 33. We did an analysis of our qualitative interviews with parents, and these are some of the themes that came out. So, like Fabiana was saying before, there's this emotional roller coaster that parents are experiencing in the NICU and after they're discharged home. Some of them experience depression, anxiety, or trauma. parents felt uncertainty about their child's health, and they took on this new role as a medical caregiver for their child. And parents also told us that nurse navigators really understood the NICU experience. They were really easy to talk to because they had met the parents in the NICU, they knew the family and the child. It wasn't just a stranger calling them for support, it was someone that really knew what it was like to be a parent of a child that was admitted to the NICU. Parents advocated for support. They said that support needs to continue long after discharge, even extending into that first year of life until the parents go back to work. And parents expressed that they were really grateful that the nurse was centralized and proactive. So the nurse was calling them. There wasn't a burden on the parents to call the nurse, and that the nurse was like the one go to person for everything for medical expertise or for well being support. And they felt like they had developed a very friendly and therapeutic relationship with the nurse. So many parents were actually sad when the intervention ended at 12 months because they had really established a relationship with the nurse navigator. So it just goes to show how powerful that support can be. And I have some quotes that I thought were really, really salient to highlight some of these themes. So this is a parent talking about the lasting impact of the NICU. And she says, just because the baby is out of the hospital doesn't mean the parents are. The parents are still medicalized. And she says, I found this study to be extremely helpful to me, knowing that I wasn't the only one who was crazy. I want all parents who have been in the NICU to have these supports because the experience of your child in the hospital is burned into your brain and you can't get away from it. You can only make peace with it, and you need a way to be able to navigate all of that. And another parent here is talking about this delayed sort of emotional processing of the experience in the NICU. She said, a lot of moms and dads are throwing up these little bombs of emotional feelings. They're getting tossed up because there's no space to contend with them. And once we're home, for me, it was close to a year after discharge where I started having space again, and the bombs come down, and you can't contend with it. And she said there needs to be an ability for parents to speak to a social worker or a psychiatrist or a psychologist, someone who's aware of how things were in the NICU and how to help you through these things. And she said the effect of the NICU experience may not always show up within the first few weeks after discharge. It could happen once they go back to work because there's not enough time and space to contend with those feelings, and then they come back. Parents also described their relationship with the nurse really positively. This one said, it was my lifeline back to the NICU. She's talking about how she really wanted to go home, but she also missed the NICU. And talking to the nurse that's in the NICU, telling her how she was doing was comforting. It was like, oh, there's someone from our hospital and they're a nurse and they get me. It's like when you have a person in a new country and they don't speak the local language, but then they meet somebody who does speak their native language, and how comforting that is. I can speak my NICU lingo and people understand me. And this other parent said, what's really awesome is having somebody who clearly understands what your experience is like. They respond to your feelings and worries in a completely supportive way because the outside world doesn't understand this experience, and the way people respond is so stressful and so unhelpful. Other comments from parents, this is talking about the ACT sessions and the mindfulness training that the nurse did. So this parent said, it's stuff that definitely stuck with me, doing all the mindfulness stuff, checking on my mental health. It's something that I keep with me. And another parent talked about feeling empowered. So she said, it builds your confidence as a parent of a preemie, especially knowing that there are people who are checking in on you and looking out for you. So you might be wondering about parenting stress, our primary outcome. We did a linear mix model to look if it was significantly different between intervention and control at 12 months. We found that it wasn't significantly different. There are lots of possible reasons for the null result, which we're exploring now. And we're also doing an ongoing analysis of our secondary measures for things like parent depression and anxiety. It's possible that the measure that we used, parenting stress, wasn't the most appropriate for the population or for the timing of the intervention. It could be that because we had such a complex bundled intervention that parents used such different parts of it that you might have just too much heterogeneity to see everyone being affected in the same way. So maybe it didn't decrease stress, but it did improve the support that parents felt, and we're just not going to pick up on that from a measure. So we're continuing to do our exploratory analysis. We also are doing a health economics analysis to see the cost effectiveness of the CCENT intervention compared to standard of care. So stay tuned to see the results of this study. And in the meantime, what we're working on alongside this analysis is our next phase. So in phase one, we were looking at the effectiveness of the CCENT trial on parent stress. And now we have phase 2, which we're calling ADAPT, assessing and developing an adapted navigator role to support parents during neonatal transition. So looking at that null finding that we had, seeing if we need to revisit either the role or the context that we implemented it in, looking at barriers and enablers to implementing this from the perspective of parents and healthcare professionals in the NICU, and then co-creating with those parents a tailored implementation strategy to guide the integration of this nurse navigator role, and looking at the implementation of the role long term. So what we're working on right now are focus groups with parents and nurse navigators to gather their experiences in doing the intervention and what they would change. And then we're analyzing that with some implementation science frameworks, and we're going to develop a strategy and a blueprint for the role. So that can hopefully be disseminated across the country if people are able to uptake this role in the NICU context long term. That would be great. So we're just working on making a handbook that could just train everybody in how to implement this at their own sites if they choose to do it. So that is our presentation, and we have time now for questions. If you have questions for Fabiana or myself, we also are joined by some other members of the study team. So Angie is here working on ADAPT, and Natasha as well, so they can answer some questions if you have questions about our next steps. Thank you so much for joining us for this webinar. And I will just wait to see if there's questions in the chat.
Thank you so much. This was really wonderful. I see Corinne had a question. Corinne, I don't know if you want to unmute yourself.
Sure. Hi, everyone. Thank you for this wonderful presentation. Fabiana, I did have a question for you after you shared your journey. I was just wondering if you had any advice to share with other families, specifically as you were showing us the Gabriel's care map. Others may be facing, resharing their stories quite often, especially when they're navigating conversations with their own care team. So what would you tell them as a first part? And secondly, do you have similar or different advice that you would provide to families who are then invited to partner in research? And then they're also resharing their experiences there.
So thank you for your question. I started part 2 because I work with a lot of families who want to collaborate in research. And we don't really know where you're signing up for when you're first starting this new career as a collaborator in research. And we always tell families, just share as much or as little as you want. You don't have to share the whole story. Also here at the foundation, we try to match families with researchers that are researching their specific child's diagnosis or some conditions that they had in the NICU. So we kind of prepare the families before they go with the match researchers so they know what to expect. But we always say just share as much as little as you want, because we know some piece of our journeys are very hard to share, and we never know when the triggers are coming, because I've been presenting my story for over 10 years now, and sometimes I do feel emotion and I don't know when it's going to happen or in which environment it's going to happen. Sometimes we had a good time present this with Kayla in a conference early May, but sometimes it's really hard. So I think tell parents, just be kind to yourself. Not every day is going to be a great day when you're doing this work, but I always think why I'm doing this work. And this is what I tell the parents, why we are doing this work, because a lot of times we are not going to benefit from the research we're collaborating, but we are helping families will come after us. So this is my why. This is why I do what I do, to really collaborate to support families after me for generations to come. The first part, I think, is a very difficult one because it's a long journey. And in the beginning, the stories, the experiences are so raw, and it's so hard to keep going over and over again, the same story. And we also are in teaching facilities where a lot of times we see the resident, and then you see the fellow, and then you see your specialist. There is this order, and sometimes you repeat more than once the story in the same appointment. And I tell you, some days I'm very patient and I have all the time in the world and I sit and it's fine. But some days I'm tired and I don't want to tell everything again. And I have reached out to nurses from doctors, specialists, and I told I cannot see a resident because I'm so tired and I cannot go over the whole story again. But for new families, it's hard because we don't know where they're coming from. We don't know where they are at in their stories. We don't know how many appointments they have. So it's always a one-on-one conversation, really, because when I talk to families and like providing peer support, I actually see where they are at, instead of giving them advice, because everybody's going to be so different and interactions with the healthcare system is so different to all of us. So it's harder to say one thing that is going to fit all families because you come from so many different backgrounds and experiences. Sorry, I don't know if I don't have an answer for the first piece of the question. Really.
No, thank you. I really appreciate your insight. I was just typing a little note in the chat just to share some thoughts as you were speaking. So thank you so much.
Thank you, Fabiana.
Thank you. Oh, sorry. Go ahead, Kate.
I was just going to say, I saw Jacqueline's question in the chat first, and I think Angie, if you want to come off mute, Angie Lim is our postdoc who's leading that phase 2 implementation. So if you want to, do you want me to read the question, or you saw
Oh,
it?
I saw it. Maybe everyone else didn't see it. So just asking about what's coming out of our phase 2 implementation study. So we don't have results yet. So what we have, our plan is we've engaged in interviews and focus groups with parents who had the nurse navigator intervention or the CCENT intervention, as well as the parents and the nurse navigators part of that. And we're in the coding phase of that right now. So we're looking at all of the results that have come out and coding that to CIFR, and then we'll be matching that to ERIC and putting together kind of what we think that blueprint will be. The next phase will be pulling together an advisory group that will have parent participants that engaged in CCENT, as well as some of our other parent action group members, healthcare professionals, some neonatologists, and some of our research team. And what we'll do is we'll go through like rank ordering of what we think is the most important or most significant enablers and also barriers on how we can put together a recommended plan that we can bring forward to other groups so that that can be implemented in the future, ideally in NICUs, but hopefully also in other settings where there's transitions that we know are complicated. So for example, some of our medically complex families, when they transition either healthcare settings or home as well, ways that we can integrate that. So we're still early on. We just finished our focus groups in February, so we're just still in the coding phase. So we will have hopefully some results coming out probably in later in the fall. So stay tuned because it will be posted and shared through ChildBright as well.
Great, thank you, Angie. Carol, I see your hands up. I'm quickly gonna go to Mark's question and then you, if that's all right. So Mark had 2 questions. First, the standard of care for the control group. So the standard of care was whatever parents would typically receive in terms of neonatal neurodevelopmental follow-up from the clinic, which was child-focused. There was no additional nurse coordinator or a navigator care for the parent. That was just unique to the study. But any other services that parents could be referred to from the follow-up clinic or in the community they might have engaged with. So they could have engaged with more mental health support. Maybe the NICU specifically that they were at had like peer support worker, peer navigator. So that was all possible. But this bundled nurse intervention was unique to people in the study that were in the intervention arm. Scalability and sustainability is such an important question, and I think something that we're going to address with this phase 2, because I do think the biggest challenge might be funding for someone in this role, because what we did was with the research funding, we were able to supplement, I think, a 0.1 or 0.2 FTE of the nurses who engaged in the intervention. So they were already employed by the NICU or the neonatal follow-up clinic. And we bought like a half day or a day, depending on the volume of the population. We sort of supplemented that time so that they could do the intervention and also so that they could attend the training. So you would need funding for the training and for that sort of ongoing supervision piece if you're going to keep the ACT element in the model. If it's just navigation and care coordination, you might be able to do it with just the nurses. And if you had like a network of nurses across different NICUs in Canada, maybe having that peer sort of facilitated discussion between the nurses so they can support each other. That would be another thing that you would need. So I think part of what we're looking at is how to make the role scalable and sustainable, and if there's ways to lower the costs or improve, the uptake. So yeah. And then Carol, you had your hand up. Thank you so much for waiting.
Hi, I know. Thank you, Kayla. It was really good to see these results presented this way. I think it would be important for people to know the timing of the study, because it happened quite a while ago, and I think there have been already some changes in, for example, our follow-up protocol, in that currently, at the time, we didn't have the 6-week visit with the mental health screening, which we now have. Many of our social workers have done ACT training and use it as a skill to teach families following this study. So I think just highlighting to people what's been done so far. I think the other thing that's happened is that the ACT training was really chosen because it also could be something that could be supported by peer parents. And I think that's something that could be explored, and particularly with CN Fund group, and maybe Fabiana could talk to that. That's something that we could talk about. But I think, just to provide people again the exact dates of the study, and so that people realize the context it's been, and that there's been a lot of change since the study finished already, please.
Yeah, of course. So it started with a pilot year in 2018 at 2 sites, and then the rest of the sites, I believe, were running from about 2019 until 2022 for the last parent follow-up. We had ongoing enrollment, and there was some slowdowns throughout the pandemic, and all of our data, I think, was captured by 2022. And so now we're in the manuscript writing and analysis phase. But yes, like you said, there's ongoing changes and things happening in NICUs and neonatal follow-up clinics, which is great. I think the parent screening for mental health symptoms becoming standard of care is wonderful as well. And like you said, parents can be trained in ACT. They can deliver it as peer facilitators. They don't even have to do a manualized ACT session. You could just have that ACT approach of, looking at that mindfulness element and feeling your emotions and what actions can you take towards your values, just for that sort of motivational interviewing, or just the way that these peers are talking to parents, even if they're not sitting them down in a formal session, they can have that approach and bring it to the NICU environment. So I think that's also great. Did I see any other hands up?
Some of our social workers are actually using that sort
Yeah.
of construct as well. So that's very helpful.
It's great. I encourage everyone to look into it if you haven't heard of it before. It's a really, really flexible and beneficial intervention. Has been used in quite a lot of parent populations now. So it's very cool. Yes, Corinne, we have an infographic. I think we have that on our website through the ChildBright website for the CCENT project. So
It's in the library.
great.
It's in English and French.
Yeah,
Yes.
ChildBright's very, very supportive with knowledge translation. And once our papers are done, I think we'll also work on making more infographics to help disseminate our findings to a wider audience.
Excellent. I don't see additional questions. Oh, Jack shared the document. Thank you so much, Jack. So yes, so thank you so much. This was really a very informative webinar, and we really appreciate all the work that you're doing. I'm going to launch our evaluation. Let me know if you cannot see it. It should be a pop-up window on your screen. And please take a moment to complete the quiz, the evaluation survey. It helps us improve our webinar series. And I want to really thank Fabiana, Kayla, Angie, and Natasha for suggesting this webinar and for hosting it for us. Thank you so much. I don't know if you have any last word, but we look forward to additional work from you, from your project.
Thank you so much for having us to share this. We're so grateful to be able to share our findings so far. You can reach out to us if you have any questions. I think probably the best way would be to find the CCENT website under ChildBright, but I can also put my email here in the chat. I also realized that I missed our acknowledgements slide, but I wanted to just thank everyone who has been part of the project, whether on the research team or a participant in our studies. We're just very grateful and grateful for the funding from the ChildBright Network that enables us to do this research. So thanks. Fabiana, I don't know if you have any last words.
No, just want to thank everyone for being here, and thank you for the opportunity to share my experience.
Thank you.